Hello, everyone. My name is Juliette van Altem, and on behalf of Professor Wilde, Dr. Amin, and Nienke Hofman, I would like to welcome you to our first webinar of our webinar series of the ERN GUARD-Heart, with today about thematic area 1, about the RyR2 variant and CPVT. I would like to mention that this webinar will be recorded and on-demand viewing will be available afterwards, and during the whole webinar the chat is open for all your questions. We have three parts of this webinar. The first part, Professor Wilde will talk about the cardiac arrest case and a workup. Then Professor Juan Sierra will talk about CPVT, and afterwards Professor Wilde will talk again about the RyR2 variant. So Professor Wilde, I would like to pass the word to you.
Thank you, Juliette. Welcome all. Thank you for attending. So this is our first webinar, and I'm sure some things will go wrong today, but we'll give it a try to start with. And I will start with this case, which will present the general workup of a sudden cardiac arrest case and how to interpret rare variants. I am sharing my screen. And the after this general case, Juan Sierra from Brussels will present a case, and then I will continue, and I hope we have time for all that. So my case is a young girl with sudden cardiac death in the family, and this is a case which was presented by Dr. Nadamani half a year ago in a meeting that I attended. An interesting case to show how the workup of cardiac arrest case, of a young cardiac arrest case, should be done. So this is a 16-year-old girl. She had suddenly loss of consciousness while playing basketball. She was witnessed by several students and teachers who described that the patient fell down as she was passing the basketball to another player. It was noted that her both arms were contracted with jerking for about 30 seconds and then remained unconscious for about 2 to 3 minutes. No, she was not incontinent. And she had to be resuscitated or defibrillated. This is her family history. The proband is below here, 16-year-old, and she had a sister who died suddenly while asleep at age 11. Her mother died from ovary cancer at age 50, and further in the family, nothing is notable. So father is still alive, no complaints. Parents of father died, and the parents of mother are both at older age and still alive. This is the EKG of the proband, and I will describe it as a sinus bradycardia with normal conduction intervals. I think the QRS is normal, although it's a little flat in the a little low voltage in the extremity leads, and there is a Q in RVL. The question though is what to do, how to proceed, and there's obviously the need for an exercise test because the event occurred during more or less exercise. She was exercised according to standard Bruce protocol, exercise time 30 minutes. Heart rate at peak 178, and this is the EKG at maximum heart rate. The QT interval remains normal, and there was no ventricular ectopy whatsoever. So, and she was also monitored while being in the hospital, and nothing abnormal occurred. Imaging was subsequently performed, and the echo.
There are some
MRI
participants. Look at it.
So I will follow this heart rhythm HPHRS consensus document that was published last year by Martin Stiles from New Zealand, and I had the honor to share it on behalf of HRS. And this is about the investigation of decedents with sudden unexplained death and patients with sudden cardiac arrest, and that is what this patient is, and their families. And this was developed by the Asian Pacific Heart Rhythm Society and the Heart Rhythm Society. And there were a number of other associations connected to it and endorsing it, and that includes ERA and many more, as you can see.
I think it's just for the
committee members are mentioned here. They are from all sides of the world. So this is a general, this document is generally accepted by most societies in the world, thereby by most cardiologists. This is how the
do you see
countries that were involved in the authorship. And the methodology obviously is similar to all other consensus documents. The writing committee reviewed the evidence and established consensus to generate recommendation. They are in the table. There is a brief synopsis and recommendation specific supportive text and flow diagrams or tables as appropriate. And the recommendations were formulated according to the American College ACC AHA class of recommendation, and that is known to all of us. Class 1 in green, class 2A moderate, class 2B weak, and class 3 no benefit at all. And then the level of evidence is also familiar to all of you, I suppose. So the threshold for any consensus within these within this document, 74 recommendations were balloted by 28 writing committee members, and there need to be a threshold of 80%, and the recommendations that were voted for reached an average of 94% agreement. The table of contents of the document is here, and we'll speak today about the investigation of sudden cardiac arrest survivor. And then first, the recommendations for is on the role that is highly established or highly stressed in this document, that there is a role for a multidisciplinary team for the investigation of cases like this. So when there is a potential heritable condition, it should be overseen by a multidisciplinary team, which as a minimum should have appropriate expertise in pediatric and adult cardiology, genetic counseling, and pathology. And that is similar to the investigation of a sudden cardiac death case or a survivor of a cardiac arrest. And a multidisciplinary team here in the schematic drawing in red is what is needed in minimum. Around that are other clinical scientists. For example, now and then you need a neurologist or a pathologist, and usually all this is in the university setting, and a registry is built up of these cases. So the first thing to do in a case like this is to obtain the personal and family history. And I already gave you the personal and family history for this particular case. And what is also important is to obtain all possible details surrounding the cardiac arrest. And that should include witness accounts and eventually medical records that are already available. Then there is, of course, a mandatory detailed physical examination. And then this long list, and I will go to that in a little bit more detail in a minute, is what is need to be done. At the left side is examination and baseline investigations. In the middle is a column with provocative testing, and at the right side is when to perform genetic evaluation. So I'll start with this, and most of this was already done. There was a personal and family history taking. There were no prior medical records. Detailed physical examination was normal. Blood samples were normal. EKG, I've shown you, was almost normal. And high precordial EKG has not yet been shown and was not performed actually. Then there is continuous EKG monitoring during the hospital stay. That was normal. Echocardiography and CMR were normal. Coronary imaging was not done, but in this young case, you can rely on the MRI as far as the coronary origin is concerned. Interrogation of a CIED that was not available because she had none. And then signal average EKG as a class 2B was not done in this case, and the AED monitoring data were not available, but there was a clear ventricular fibrillation episode. Provocative testing is important. An exercise test was performed that was done. A sodium channel blocking challenge will be shown in a minute. A lying to standing EKG for possible long QT syndrome was done, was normal. EP study can be considered, and other investigations are mentioned here with the class 2B, for example, testing for coronary spasm is useful, but not in a very young individual. An adenosine challenge to unmask pre-excitation, etc. And then genetic testing. When there is a genetic phenotype identified or suspected, you can clearly go on with phenotype-specific genetic evaluation. That's a class 1 recommendation. If that is, but also broader testing is allowed with a class 2B. But in general, there's no recommendation in cases where there is no established non-genetic cause. So routine use of genetic evaluation is not indicated. And you may consider a channelopathy or cardiomyopathy specific genetic evaluation as a class 2B indication. So this genetic testing was done here. And in this case, there were 3 variants of unknown significance identified, one in myosin heavy chain 6, one in the ryanodine receptor, and I will come to that later in my second presentation, and one in this gene SOS1 that is not in the heart. So the relevance of the 2 variants is unsure. There's unknown significance. There was no material available of the diseased individual. Parents were not available for investigation, and so it will remain unclear whether this variance means something, but I'll come back to that later. So if I go back to this list of provocative testing, then one thing to do, and also in all cases, and particularly also in these very young children, is this sodium channel blocker challenge, the Ashmalin test. And I'm not sure whether everyone is doing it, but this case is a clear example that there is a good reason to do so, because this was the EKG after Ashmalin administration, and this is clearly abnormal. There is a marked left axis deviation. There is a marked PR interval prolongation, and there is marked ST elevation here in the right precordial lead V2. And I think also here, this is a little later, also here in V1. So this case can be diagnosed as Brugada syndrome, and I think it's actually a little bit unexpected at the starting point of this case, but it shows the reason to go very consistently and very systematically through the workup of a cardiac arrest survivor in order not to miss this. So this is the case so far. We are a little bit experiencing whether we can do this interactive. We decided for today that we will not do so, but it's obviously open for questions. So if any one of you has a question, please put it in the chat, or we are not with so many, so you can also open the microphone if you like. I will stop sharing now. Is there any question on this particular case?
Arthur, I have one question.
Thomas, we don't hear you.
Do you hear me now?
Yeah.
Okay. So I have one particular question on the Ashmalin testing in children, because there is some doubt on the safety of performing an Ashmalin test in patients below 16, because there are some reports on increased prevalence of malignant arrhythmias in these patients. Of course, in the case of a sudden death, that's maybe a different approach. But well, we are a bit reluctant in doing these Ashmalin testing in children, actually.
Yeah, so my personal approach here is that I would be very reluctant if you have conduction abnormalities on the baseline EKG and that you are expecting a sodium channel variant. Then I would not do it. I don't think it has any reason also. But in a case like this, I think with good monitoring, you can do it in a safe way. Also in females, it's probably less of an issue than in males. But if there is any suspicion of a sodium channel variant, I would be reluctant. And another thing to note is that that is data from Brussels, that in very young, you might miss a positive test that later on in life becomes positive. So a negative test at very young age, I don't think this is this age, but younger than this, is an issue. Okay, if there are no further questions, I'd like to ask our colleagues in Brussels whether they can present the second case. I'm not sure whether Luigi Banone is doing that or whether we have to wait for Juan Sierra. Does anyone know in Brussels, Luigi or Sonia, do you know whether?
Hello?
Yeah, hello.
Hello, Prof. Yeah, one is here, and he's arriving. He's coming.
Okay.
Yeah, probably if you can do your presentation, you can switch. Yeah, because one is there, but he's coming.
Okay.
So yeah, we have still 10 minutes. So probably we can switch. You can do first your presentation, then one will do his own presentation. Is okay for you?
That's okay.
Okay, thanks.
So my second presentation is on ryanodine receptor variant, as was actually identified in this case. What should then be next? So I'll first introduce a little bit about the cardiac ryanodine receptor, encoded by the RyR2 gene. This is a protein in the membrane of the sarcolemma sarcoplasmatic reticulum, and it's responsible for the release of calcium from the SR into the cytosol, as indicated here in this schematic drawing. So this is a small movie indicating it. The SR is in the cytoplasm of the cell. Calcium is stored in here, and upon an entry of calcium through the calcium L-type channel, there is a release from calcium ions from the SR, which then subsequently is needed for the contract filaments to work. So calcium enters through the calcium, the L-type calcium channel. The calcium is released, and the contractile filaments are able to do what they need to do. And then calcium subsequently is pumped back into the SR through this construct here, including phospholambam gene and SERCA2A. So calcium, ryanodine receptor related disease is first of all CPVT, subtype 1, catecholaminergic polymorphic VT, subtype 1. But there is also a condition that has been termed initially adrenergic ventricular fibrillation. That is one of the subforms of idiopathic ventricular fibrillation. And there is short-coupled torsade de pointe, which is also part of the under the umbrella of idiopathic VF. So the pathophysiology of these diseases is that when there is a ryanodine receptor variant with a gain of function that leads to CPVT, subtype 1, when there is a loss of function that leads to can lead to adrenergic ventricular fibrillation and short-coupled torsade de pointe. And I will go through that in detail. So I first start with CPVT. That is a disease which is autosomal dominant. As we know, it's genetically heterogeneous with 6 genes, and ryanodine receptor is the most important one. Complaints usually occur during exercise and emotion and other adrenergic triggers. It can start at young age, and the baseline EKG, importantly, is normal. The penetrance of the disease, these are early series published in 2002, between 2002 and 2009. The penetrance of the disease, importantly, is not 100%. So it's in the range between 70 and 85%. So 15% of patients with a ryanodine receptor do not have an abnormal exercise EKG. And the response to beta blocker, that is not for today, maybe later with the case from Brussels, but not for today, is not 100%. So this is a series from our own, where we just followed family members to get some idea about the disease penetrance and the expression of the disease in family members carrying a ryanodine receptor variant. And this is the number of patients was 116. 4 were already on the beta blocker. and 4 were on the, so 8 together were on a beta blocker. 108 of these individuals were beta blocker naive at the time they were seen for the first time. And when you do an exercise in them, the phenotype is there in 50% of individuals. And when you do, and the other 50% has no phenotype available. If you reevaluate those with a negative test, some do have a phenotype and others remain negative as to the phenotype. So the penetrance of this cohort is in the range of 2/3, 60 to 70% when you do 2 exercise tests. If you limit it to 1 exercise test, it's only 50%. Genetics in this disease, in this disorder, is that the vast majority is a ryanodine receptor, 2/3 of cases, and 1/3 of cases is negative. And there is a minority where you find one of these other genes. Some of them are actually autosomal recessive, like the Cas-Q2 and the trinodine. So they are very rare diseases. Now, this is one of the first papers with a database of patients with these ryanodine receptor variants, and they were located in a number of predilection sites in the gene. So there were a couple of sites that had more variants than others. And the yield of genetic testing is very much dependent on the presentation of the case. And that is important for what is upcoming now. So I have 2 cases here, the yield of a syncope during exercise, and when there is on the exercise test, the hallmark of the disease, the bidirectional tachycardia, and you can be sure that the yield is very high. But if there is a syncope during exercise and the exercise test has no ectopy, the yield is a lot lower. And that is important to realize. So these are the numbers from this particular paper. In the total cohort, the yield was just below 50%. In the CPVT cases with a strong phenotype, you find the 60% as expected. And in CPVT with a possible phenotype, it's already a lot lower. And in G-negative long QT syndrome, that are patients who were initially diagnosed with long QT syndrome, but were negative and then subsequently screened for ryanodine receptor, so they have a weak phenotype, you find only in 1/3. And that is half of the patients with a strong phenotype. Now, that is important because you use that in test interpretation, and I'll take you to this paper. This is on a much larger cohort from the Mayo Clinic and from our center. The age of genetic testing is very important in predicting whether you're going to find a variant in the ryanodine receptor, and that is in young individuals. You find it much more than in elderly over 35, which is not that old, by the way. But in young, it's very high. In elderly, it is much less. And that is important because the red dotted line here is the line where the background rate of rare ryanodine receptor variants is found in the exact database. So that's 3.2%. So in every individual, in 3.2% of background individuals, you find a rare ryanodine receptor variant. So then I go back to the strong and possible and referral cohort as to the phenotype. So in the case of a strong phenotype, you have a 60% chance of finding a rare variant. In the case of a possible phenotype, it's only 30%. And in this referral cohort, it is only 18%. And if you then take into account the exact background rate of rare ryanodine receptor variants, it becomes important that the chance that you have that you predict that your ryanodine receptor is meaningful is 1 in 18 in a strong case, so 60% and 3%. So 1 in 18, you are correct. In a possible case, it is 1 in 10, and in a general referral case, it's 1 in 6. So the case that I presented in my previous talk was a case where with a negative exercise test and the event occurred during exercise, but not really exercise, is at most a possible case. And then there is 10% chance that your ryanodine receptor isn't meaning anything. if it's a referral case, it's only 1 in 6. And then finding a variant, this is the different prevalence of variants in the exact database, in the referral database, and in the phenotype database. You can see there are definite predilection sites. So if you find a variant here, it is a very high chance that it means something. If you find a variant here, that is also the case. But at other sites, the exact the prevalence of exact is, for example, very similar. In this exon 37 is very similar to phenotype cases. And we use that information in this paper published in 2019. So many of the ryanodine receptor variants nowadays come back as a variant of unknown significance. But if you know that in a strong phenotype, the chance that you're dealing with a real ryanodine receptor variant is much higher than in a weak phenotype, you can use the phenotypic information to promote or demote ryanodine receptor missense variants. And that is what's done in this paper. I don't have the time to go through all the methods, but this is the final result. If you use the ACMG classification framework, you end up in the Mayo cohort with 50% of variants classified as pathogenic or likely pathogenic. But if you include the phenotype in that classification, then you have a large number of variants of unknown significance that are promoted to pathogenic or likely pathogenic, and the yield is 75%. This is obviously at the expense of variants classified as variant of unknown significance, and that is what you see here. And also a few variants are benign as to CPVT. And very similar data were from our own cohort, so also a marked increase in upgrading variants and a marked decrease in downgrading variants. So in conclusion here, in strong cases, strong phenotypic cases, ryanodine receptor variants mean something, may actually mean that they are CPVT related. But in weak cases, and the example that I started with today is, I would consider a weak case, be very careful with the interpretation of that particular variant. So that includes sudden cardiac death without further details, and use the phenotype wherever you can. So finding a variant is not identical to having CPVT, and also take into account the 3% change of a background noise. And in resuscitated individuals in particular, there is the possibility of loss of function variants. So that is the disease referred to as CRDS, calcium release deficiency syndrome. I'll come to that in a minute. This was the first report on loss of function ryanodine receptor variants. This was it was, by the way, a report without functional data, but it was a large pedigree on 2 novel familiar compound mutation in the ryanodine receptor. These patients presented with idiopathic ventricular fibrillation. It's a very large family. 2 ryanodine receptor variants present, 7 mutation carriers. 4 of them had aborted cardiac arrest, and 2 of them had cardiac arrest. And out of these 7, there were adrenergic triggers in 5, but 7 had 7 more without data also died in this family. This is the paper that I would like to stress. This is on the cardiac ryanodine receptor calcium release deficiency syndrome. Dr. Wayne Chen from Calgary in Canada is the main author here, and the basic scientist who has done all this work. These are the ryanodine receptor variants that were identified in patients with aborted sudden cardiac death or sudden cardiac death, or both when there is a family history. Importantly, the exercise stress test is negative in all these individuals, and there are symptomatic mutant carriers. In some of them, there are 5 out of 8. That is the family that I just described. And others is also clear family history. If the family members that are negative are all asymptomatic, and the impact of the variant is a loss of function of the ryanodine receptor. These were the published cases that were in the literature, and they all have the same characteristics. So the way to show whether there is loss of function, of gain of function of the ryanodine receptor protein is by the way of a caffeine-induced calcium release. This is the ryanodine wild type. So with increasing concentrations of caffeine, there is increased release of calcium. And if there is a loss of function, then that means that the protein becomes less sensitive to calcium. So there is a shift to the right. You need more caffeine to induce calcium release. So that is loss of function for all these particular variants. And these are the raw data where you can also see that you need more calcium to obtain the same calcium release. And this is the way then to put that in graphical. That is the EC50 of caffeine activation. The higher it is, the less sensitive the ryanodine receptor protein is for caffeine. So that is a loss of function for all these ryanodine receptor variants. CPVT patients have a gain of function, as we know. So in a very similar setup, here you have increased sensitivity to calcium release. So the curve shifts to the left instead of to the right, as in the previous example. Now, what is known in this cohort? This is data of mice. This is a mice with a loss of function, a ryanodine receptor variant. And in the mouse, the investigators obtained a very specific pacing protocol for arrhythmias. And the pacing protocol consists of a long burst and a long followed by a long pause and then a short coupled extra. So you have a burst, you have a pause, you have a short coupled extra, and then ventricular fibrillation is induced in this mouse model. It's transient here, but it's a typical characteristic of the mouse. In the gain of function mice, so this is a CPVT mice, this particular protocol does not lead to any arrhythmia, nor does it in the wild type mice. Now, does that make sense? So this is a summary of the data in the mouse. And this, interestingly, is data from a mutant carrier, so from a patient. And these are data from an ICD recording, where there also seems a burst of RR intervals are fast here. There is a burst, there is a pause for one reason or another. So this is the pause. Then there is a short coupled extrasystole, and that leads to VF. So this was the first example in a patient where a very similar protocol, stimulation protocol, and this is a spontaneous event, led to VF. This is during EP study. So this is the mouse data up here. This is an EP study in a patient with a loss of function variant. So there is a burst, a long pause, and an extrasystole that leads to ventricular fibrillation that is recorded here with a 12-lead EKG. This study had a follow-up study of Thomas Rosten, also from Vancouver and Canada, with a lot of some more patients. There were in the registries that we run 24 candidate ryanodine receptor CRDS cases, 10 probants and 14 relatives. The functional characterization of these variants is here, and the summary is here. This is the wild type, so there are a number of loss of function that are these variants, and these variants are gain of function. Here the ryanodine receptor is more sensitive to caffeine, here it's less sensitive to caffeine. So these are the variants that are expected to lead to this particular phenotype. And then based on these variants, there are 19 patients, 6 probants, 13 relatives. A few have a gain of function and have a CPVT, and a few are actually wild type like and potentially mean nothing. So in summary, adrenergic VF does exist. It is based on loss of function. Ryanodine mutations are causally linked. The exercise test in these patients is usually normal, although and occasionally an extrasystole can occur. The pathophysiological mechanism is still complex, and the diagnosis at this point in time is only through functional ryanodine receptor studies. But the question is there a potential specific pacing protocol, and further studies are required? And actually, in the meantime, one of these studies has appeared. This is from Dr. Watkins from Cambridge, where he also described a very large family and he did this provocative testing and also investigated the therapeutic response in this particular syndrome. These are patients in his cohort, and they all are very sensitive to this protocol. As you can see, not all. Here's one that is not inducible, but all the others are inducible. Non-sustained polymorphic VT or VF is induced by the protocol of a long burst, a pause, and a short exosystole that then leads to an arrhythmia. So in this family, there are many affected. Exercise tests are negative in the vast majority of them. The baseline EPS is positive in some of them, but not in all. Flecainide seems to be effective in most of them, so not in all, as you can see. And metoprolol doesn't seem to be effective. So the medication of choice in this disease probably is flecainide. And there seems to be an apparent relation between inducibility and severity of the phenotype. So calcium release deficiency syndrome is autosomal dominant ryanodine receptor variant with loss of function are responsible here. At present, the diagnosis, I think, still requires functional data, and not much is known yet because there are only 4 publications. Patients may be identified to a specific pacing protocol. Flecainide may be protective, and beta blockers are probably not. But there's still much to learn, and we are working on a registry in this for this disease together with the Canadian group led by Jason Roberts, and we welcome, of course, collaboration. So this was it on the calcium release deficiency syndrome. It is open for questions. If anyone wants to address one specific issue here, please go ahead.
I would like to pose a question. Bo Winkledam.
Oh, yeah.
Yes, thank you, Arthur. Very, very interesting. I have 2 questions. One of them, or maybe 2 things that you could elaborate a little bit on. One of them would be the actual exercise stress test, because there are some studies out now that probably we are not all doing the exercise stress test in the same way, and probably it will be sensitive based on how you do it. So I was just interested in hearing, how do you perform your exercise stress test? Is it at treadmill, or is it running? And do you do that as a burst or as a sprint protocol? So
Yeah,
that was
so
one question.
Yeah, let me first address this
Yes.
question. So the sprint protocol is recently put forward also by the group from Vancouver. May be more sensitive for CPVT related arrhythmias than a regular stress test. We don't do the Bruce protocol here, but we used to have a super Bruce protocol, which means that we just abbreviate the intervals, and that more or less becomes a sprint protocol like thing, because you are very quick in the more advanced stages of the test. So I think a regular Bruce protocol is developed for elderly patients to see whether they develop ischemic complaints or ST segment depression. That I don't think that is the correct way to do it, but a more stressful way is probably better. But I don't have experience with the sprint protocol as they did in Vancouver. But for the CRDS, I'm not sure the stress test is sensitive at all. It's also not expected because you need these pauses, and in a regular stress test you don't have pauses.
And that, thank you, and I agree with you. But that also leads to the other question, because this is a genetic, or you see this disease entity based on the genetics, basically, right? At currently, we would not recommend doing genetic testing in all idiopathic VF patients. But I guess that if you want to find this disease, you will have to do it.
Yeah. That
kind of puts you in a dilemma, right?
Yeah, no, I agree. And that is not yet, so we have no idea about the yield.
No.
If we look in our own cohort, we have always done it and I think you as well, in the research setting, doing these genetic tests. And now and then you do find the ryanodine receptor variant.
Exactly.
Which does not qualify for a CPVT variant. And that probably is this CRDS leads to this CRDS disease. So if that is a more frequent thing than we thought, then we have to reconsider the genetic test and a resuscitated individual without in an IVF patient. So that is an issue at the moment. I agree.
Yeah. Thank you so much.
But we have started now in patients with the IVF. We have started now to reintroduce the pacing protocol, so an EPS with this specific pacing protocol, because I think from the data that are out there, it seems to be a very sensitive protocol. So you may pick them up by the pacing protocol.
Yeah, I agree. Thank you.
Okay. Then we have some time left for the case from Brussels.
Yeah.
Yes.
Hello, one is here.
Hello, can you share the screen, please?
Yes. We just apologize because actually we have a technical issue with the case and we'll present a bit related topic on risk stratification of channelopathies. Okay, thanks.
Please keep the time in mind. We have 5 minutes officially, but it can be 10 minutes, but should not be.
Okay. Okay. Do you see
Yes.
the presentation? Okay, perfect. I will go through very quickly. I will present the risk stratification in inherited ventricular arrhythmias and sudden death. So we start long QT, BRS, CPVT, short QT. The inherited arrhythmia syndromes account for 1-2% of the total case of sudden cardiac death and 10% in Japan. When we look at the different etiologies, long QT is one of the most common, together with the Brugada syndrome, and it's defined as longer QTC, longer than for 40 male and for 60 milliseconds in female. Risk stratification is based both on the ECG, so on how long is the QT interval, or also on genetics and other features that we'll see. So long QT1, for sure, it's important that the sex, so male sex is a higher risk. The QT, so QTC more than 500 have a higher risk of arrhythmias, but also genetics. And so the mutation of a KCNQ1A341V is associated with a worse prognosis. And then long QT syndrome 2, female sex are associated with a higher risk, but also ECG and genetics. So the poor mutation in KCNH2 is associated with higher risk. So also in this case, genetics is important. And then long QT3, here genetics is, there are less data about the genetics. We know that is associated with higher risk. So long QT has higher risk by itself compared to long QT2 and long QT1, and male sex has a higher risk. Let's see, yeah, this is a recap. Now we present briefly Brugada syndrome. You know that we are from UZ Brussels. So here, this is the main topic, of course. And from a prelude registry, we have that spontaneous type 1 is associated with higher risk. And from finger registry, symptoms like previous sudden cardiac death, syncope, spontaneous type 1, EPS are associated with higher risk. And this is our score, Brussels score, in patients, so from Prof. Sierra, that is here, and spontaneous type 1, early familial sudden death, inducible EP study, syncope, sinus node dysfunction, sudden cardiac death are all associated with the worst prognosis. And recently we have Shanghai score and the ECG score for Brugada syndrome. What about the genetics? Sergio, guys, sorry, we are presenting. So what about the genetics? Genetics, SCN5A, we know that is associated with the worst prognosis, mostly because a worse epicardial substrate. This is a study from the group of Milano, Papone, and that demonstrated that SCN5A is associated with the higher, larger substrate on epicardium. And this is from our center. So we demonstrated that based on the potentials, so high frequency potentials and low frequency potentials on epicardium of RVOT in Brugada syndrome, these potentials are longer, are more fractionated in patients with the SCN5A mutation. And we demonstrated both with the high density mapping, that is this, and both with the VEST, with the non-invasive ECG imaging. And we also demonstrated that ECG imaging can be useful for risk stratification of Brugada syndrome because patients with previous sudden death had longer, prolonged activation time. So like a prolonged activation time of their VOT. And finally, just a few slides on CPVT. Prof. Wild already explained this disease and a bit of a risk stratification. So absence of beta blockers and history of aborted cardiac arrest are predictors of events in these kind of patients. And about genetics. So a mutation in C-terminal channel forming domain of RyR2 is associated with a higher risk of events in CPVT. And that's it. So final message is genetics is useful for diagnostic of our patients, but also for risk stratification. And I think that it's useful in our ERN group that we go towards improve the risk stratification based on genetic background of patients. Thank you.
Thank you. Luigi, can you stop the sharing?
Yeah. Thanks.
So my personal opinion is that I agree that genetics is important. Brugada syndrome is a good example where we have thought maybe for 15 years that genetics was not so important, but I think that the main problem of that is that in the early series there are many SCN5A variants that are not pathogenic, and they are in these cohorts. So that's why I think in the early series you don't find a signal for the sodium channel variants, whereas in the later series you clearly do, because the calling variants is much more sophisticated nowadays than it used to be 20 years ago, 15 years ago. In other disease entities, we are already using genetics much more. In long QT syndrome, there's no doubt that genetics is important. But we need large series to prove that it is, and that it's because, you know, in hypertrophic cardiomyopathy has many examples where initially malignant variants were identified that later proved to be benign as well. The very same variant in the very same gene. And in long QT syndrome, that might also be the case, although they are not, the examples are not there as far as I know. And of course, there are some malignant variants, there are some benign variants, but the vast majority will still be somewhere in between. So genetics plays a role, but it's not only genetics, as you know.
Yeah, I completely agree.
Yeah. Is anyone else who would like to add something? No, if not, then we call it a day. I thank you all for this attending this first call, this first webinar. We hope to do it more. Yeah, so we hope to do it every month, every last Wednesday of the month at noon, at the same time interval as today. And we hope to do it based on cases, which means that we hope that you will send us cases and that you are willing to present. So the next webinar is not planned in August because that is at the ESC meeting, or just the day after, so that is not a good moment. But the next one will be planned on September 28th. We are waiting for cases from your side and hope to have a very interactive future with these webinars. Thank you all for attending today, and have a nice day and a nice summer holiday. Bye-bye.
Bye. Thank you for the initiative. Bye-bye.
Bye-bye.